We shall go on to our first speaker, Dr. SATHIAN NAGAMALAI, who is the president of IMA Society, IMA of Coimbatore, and also is a medical director of the Eye Trust Hospital and Kobe Glaucoma Center, a very versatile, young, dynamic surgeon. And he is going to tell us something very relevant. How do you identify the patients at a high risk of complications from glaucoma surgery? That's a challenging topic. Let's hear you make it as interesting as possible. On to you, Dr. Satya.
Thank you very much. Good evening, everybody. I'm Dr. Satyan Nagamalai from Coimbatore. I thank AIOS ARC and Dr. Chitra Ramurthy Madam for giving me this opportunity. I'm here to talk about identifying patients at high risk of complications from glaucoma surgery preoperatively. So glaucoma surgery is an option in case of resident cases where IOP could not be controlled with maximum medical therapy. This surgery disrupts the globe integrity, leading to complications. To reduce these complications, surgeons should know how to recognize and anticipate preoperatively, to take preventable surgery steps intraoperatively and manage them accordingly. So Cranes described trabeclectomy in 1968, and still it remains a gold standard. And the pre-existing risk factors and success augmenting mood modulating agents led to various complications. And timely detection pre-operatively and intraoperatively and managing it is vital for good surgical outcome. So I'm here to talk about 10 pre-existing factors which might influence the outcome of glaucoma surgery pre-operatively, and it helps in preventing glaucoma surgery, glaucoma surgery related complications. So patient, number one factor is the patient age. Younger the patient, you have to think about whether you have decide whether you have to going to do the surgery under local anesthesia or general anesthesia. If it is general anesthesia, there are IOP modulating general anesthetic drugs which has to be taken into consideration. And younger patients are known to have thick tenons, and excising it or managing it accordingly will help in preventing fibrosis, where younger patients have high risk of fibrosis. When you think about operating older patients, fragile thin conjunctiva, which is opposite to younger patients, and careful handling of conjunctiva during the surgery to prevent conjunctival tear or buttonholing, which is one of the commonest complications encountered by the surgeons. And risk of systemic factors like diabetes or hypertension. Diabetes in case uncontrolled can produce a risk of infection, and hypertension can induce bleed. And older patients with advanced glaucoma have much higher chance of wipeout compared to younger one. So second factor is patients on anticoagulants need to stop prior to surgery at least 3 to 5 days according to the based on the advice from the physician. And when patient on anticoagulants with retrobulbar block can lead to acute retrobulbar hemorrhage, proptosis, SCH, and retrobulbar associated bleeding as risk factors. And it can also compromise optic nerve blood supply, and it can also lead in difficulty in maintaining hemostasis during surgery, which is very detrimental for deciding the outcome of glaucoma surgery. And excessive intraoperative bleed can predispose to blood failure and difficulty in suture lysis even after 2 weeks. And these patients can have an additional risk factor with the risk of suprachoroidal hemorrhage. Other risk factors of increased intraoperative bleed, as I said earlier, is uncontrolled hypertension. Never touch a patient, measure the blood pressure prior to surgery, and look for these patients whether they have taken those medications on the day of surgery. And patients with increased capillary fragility has to be considered for risk of bleeding, and hemostasis has to be achieved based on that. Coming to the third risk factor is the refractive error. When you do a refraction in these glaucoma patients, look for high myopia and hypermetropia. And when you think of high myopia, then these patients will have the tendency to have thin sclera, and these have higher risk of suprachoroidal hemorrhage. And hypermetropia, these patients have shallow chambers and additional risk of malignant glaucoma. Then, so doing a refraction and knowing the refractive status prior to glaucoma surgery is very, very important. Coming to the fourth risk factor, very high pre-op intraocular pressure can lead to thin scleral flap when you are raising it, because when the globe pressure is higher, then the tendency for us to create a thin flap is much higher. So you have to be very careful about it. Then premature antechamber entry, choroidal detachment, and sudden decompression. So I gently use a side port, keep the side port in the side port until required decompression has happened very slowly. So you should not remove the side port suddenly. It can lead to sudden decompression and choroidal detachment. And these patients with advanced cupping can have a risk of wipeout phenomena. So adequate reduction is mandatory for reducing the risk of complications preoperatively. Reduce the intraocular pressure to an optimum level to prevent these complications. Coming to the fifth factor, the conjunctival factor. Conjunctiva plays, as I said earlier, older patients will have thin and fragile conjunctiva. Likewise, patients, when you are planning for a repeat RAB in a previously operated eye with scarring, then these patients should be carefully examined in the OPD. Look for a viable conjunctival area, mark or draw it in the case sheet prior to taking up these patients for surgery, and these areas should be marked in the OPD prior to surgery. Very important. And inadequate space for repeat filtering surgery, in my experience, have problems with suturing and early bleb leaks. So you have to be very careful about not involving the adjacent bleb or the conjunctiva which was influenced with mitomycin have a tendency to leak more when compared to a primary trap. So conjunctiva. So two nasal or two temporal areas, technically difficult and challenging, and risk of infection and injury is very common when these blebs are exposed outside the lid coverage. Patients on long-term glaucoma medication can lead to meibomian gland dysfunction and excessive fibroblast migrations. I generally stop drugs like prostaglandin, pilocarpine, bromelain 3 or 5 days prior to surgery and put them on topical steroids, and can control intraocular pressure with oral medications. Look for Sturge-Weber syndrome and plan the surgery in Sturge-Weber syndrome based on the area without dilated episcleral veins, and we should be careful about positive pressure and bleeding. Coming to the sixth risk factor, sclera. Look for thin sclera in case of congenital disease like osteogenesis imperfecta and acquired like iron deficiency anemia. Nothing wrong in doing a hemoglobin, especially for a woman who is planning to undergo a glaucoma surgery to rule out iron deficiency anemia. Then people with high myopia, as I said earlier, has thin sclera. Chronic inflammatory disease like rheumatoid arthritis and scleromalacia preference has the tendency to have thin sclera. You have to be very careful about, and previous scleral injury has to be looked for. So careful about retrobulbar block in case of thin sclera, and also very careful about raising flap, and a wise decision about using antifibrinolytic agents is very important. If you feel apprehensive, then probably you can use a spacer or tissues like collagen tissues like collagen to prevent any scleral related complications. Coming to the shallow entry chamber, these patients are of axial hyperomic chronic angle closure with PAS. There is an increased risk of aqueous misdirection, postoperative shallow chambers, and careful about lens touch when you are entering the antechamber. Positive pressure and iris incarceration into the ostium are all factors which you have to keep in mind when you see a patients with shallow chambers. And these complications or risks are higher regardless of having patent iridectomy or iridectomy. Coming to iris, eighth risk factor, peripheral anticyanic can lead to iris damage during surgery, iris incarceration into ostium, and risk of malignant glaucoma. And neovascularization of iris can lead to intraoperative bleed and progression of fibrovascular membrane in the angle. So it can be usually combined with anti-VEGF factors, or at least 3 to 4 weeks prior to a TRAB, you can have an anti-VEGF factor injected, and then you can plan for a TRAB. It works very well. Coming to lens, look for aphakia.
You have 1 minute remaining, sir.
Yes, sir. It's about to finish. Aphakia, look for aphakia and vitrectomized eyes, and these patients have higher risk of suprachoroidal hemorrhage. Spirophakia, we had to take a decision of doing a trabeculectomy with or without lensectomy, which carries variable success rate. It's surgeon's purview, and you have to decide whether you are going to do a trab with or without lensectomy. Coming to the 10th and last risk factor, advanced glaucoma, advanced cupping with tubal fields, look for macular split and 10-2. It's a medical legal requirement. So need to explain the risk of wipeout phenomena prior to surgery and document that you have noted a macular split and you have explained about my wipeout phenomena to the patient and the attenders, and get a proper written consent. So conclusion, careful pre-op evaluation will help in better planning, modifying surgical technique and preventing post-op complications. Thank you. Thank you very much for the opportunity.
Thank you very much, Dr. Satyan. That was a wonderful talk, and I think you left nothing uncovered. So, but however, we would go on to discuss. Dr. Harsh, you are there with us. Dr. Harsh, are you there?
Yeah, okay.
I was just
So,
wondering,
Chitra,
yeah, I wanted to ask a question. Are there any category nowadays? Is there anything there when you would think of not using metabolites in a trabeculectomy surgery? When you would think about using it? Some of which, of course, Dr. Satyan alluded, but however.
Yeah, there are two important things. One is that we just are going to publish a paper about trab in pregnancy. So obviously, in those situations, you just cannot use. As a matter of fact, there's no way you are going to use any chemical over there as and when you want. The second thing is that
what would be your explanation for that?
No, because especially in first and second trimester, you are really wary that there could be some kind of a problem with the organogenesis and things like that. So you definitely, at least in the first trimester, you will definitely not like to use any fibrotic. The second thing is in high myopes, like I think he very rightly pointed out, and when sclera is thin, you would probably go for collagen. And I just wanted to fill in that in situations like this, sometimes we have already published a paper in 2008 where we used anti-VEGF. And I can promise you it works wonders. I know it is an expensive thing, but the point is when nothing else is there for you to cover up, the anti-VEGF actually serves the same purpose as the anti-fibrotic. It prevents fibroblast migration. It prevents the vascularity for 3 weeks, and that is what you want for the bleb to form. So I think one has to be.
And would you think a little differently in some of the systemic collagen disease? I mean, I myself would like to know collagen vascular disease. And would you at all think in an elderly patient with fragile conjunctiva, like I would use an antimetabolite there, but I want to be corrected if any of you would think of using a lower dosage in those cases? If the conjunctiva looks very thin?
Classically, if it's a thin conjunctiva, old patient, I don't think we really need it at all. The problem is that now in practice, I think we are also tensed up that the patient should not fail. Yeah. And I think we are a little overusing it. But yes, you are absolutely right that possibly if we are going to use it, we are going to use for lesser concentration and lesser time. Yeah, yes. That's right. Absolutely.
Yeah. Dr. Krishna Das, are you there? Has not joined in yet. Okay. Anything else you would like to add, Dr. Harsh?
Yeah, one very important thing is that if the other eye has got problems, so you see many times that one eye has gone into malignant glaucoma post-surgery, then you have to be very, very careful because the other eye can also land up with those kind of situations. So that is one point that we have to be careful about.
And the other important thing, would any of us still consider stopping the topical steroid drops to avoid chances
Dr.
of
Chitra?
Yes,
Dr.
yes.
Chitra? Yeah, I can be heard now. Yeah. I just wanted to add a couple of things to which you and Harsh had actually added value. Yes. One is in juvenile glaucomas. In most juvenile glaucomas with especially onset lesser than 30, 35 years, the sclera tends to be a little fragile, tends to be a little inelastic and less resilient than in adults. So in these group, the hypotony maculopathy is much more common. especially when we overuse or use higher dose of mitomycin. So it is in this group I totally avoid. And next, in very high myopes, again for the same reason you mentioned in collagen vascular disease, when sclera tends to be thin. In most myopes, the sclera also is less resilient, and the risk of high. So in these two groups, in addition to what you have mentioned, I would like to avoid any antimetabolites altogether. If there is a possibility, please use biocollagen like Ologen, or many of these patients do well even without any antimetabolites. In some of these patients, even with the Ologen, I've seen thin cystic blebs. So that's really, really a risk which we need to consider.
Would you consider stopping anti-glaucoma medication even in a planned surgery? Are we any of us doing that, believing that the bleb formation would be better? Or is it a purely a theoretical discussion?
Anybody else would like to add to that? I normally don't. Practically, it's been difficult for us. But I would prefer to discontinue some of the medications, especially prostaglandins, and probably even brimonidine. That leaves out only dorzolamide and timolol, I think. But most of these glaucoma drugs, even as early as 90s, it's been published that they can be cause a lot of morphological changes in the conjunctiva, including inflammatory cells, including lymphocytosis, which contributes to filtration failure. So ideally, it is better to stop these drugs probably 2 to 3 weeks, if feasible. I don't know how far it's practical, and substitute with oral carbonic anhydrase inhibitors. And also, if that is not feasible, at least add low-dose steroids for a couple of weeks. And there are reports that topical steroids do help in reducing filtration failure.
Dr. Craig, would you want to add something beyond all the wonderful inputs given by Dr. Krishnadas? Dr. Craig, are you
no,
there?
I think, yes, can you hear me?
Yes.
Yes. So my what I tell my fellows, I think you can always cut sutures. It's always better to leave the patient a little bit higher and to be able to manipulate and adjust the sutures. So we have a different population here, and so we often use argon laser suture lysis to manage postoperative bleb management. But I think in your particular population where you have very thick tenons, using releasable sutures is a very nice technique. And being able to place those not on the cornea side, but actually on the fornix side is ideal. It's more comfortable for patients and much easier to manipulate those sutures rather than leaving them embedded in the cornea. So that is my preference for patients that have very thick tenons, is to do a releasable suture that is tacked up on near the superior fornix.
Dr. Murli, would you take any question?
Yes, Madam, I would like to ask the panel, what is your take on doing a retrab in patients with a late failure of trab? Let's say trab has worked fine for 2 or 3 years and then it has failed. So how do you decide whether you would do a second trab or would you rather put in a tube?
Okay, so if we have a clear area and the conjunctiva is mobile over there and your initial trab has worked for quite some time and there's no other contraindication to doing a trab per se, then definitely we are doing very, very commonly a second trab before we go on to a tube. So the most important thing would be is the first trab worked for a long time, and then why has it failed? So you please see why it has failed and then try and incorporate it into your second trab. But if you have a fair enough area where you are not going too temporal or too nasal, and yet you are able to do another trab, then definitely we would prefer to do another trab.
I have a point to make.
Yes.
When you are planning a primary trab, just focus on either temporally or nasally, or slightly away from the midline, so that you have enough space for a repeat trab. So the primary trab, if somebody has done, then you cannot help it. If you are doing, or if you are planning a surgery for a patient with primary trab, then focus on having a trap slightly off from the midline, either nasally and temporally, based on your right-handed or left-handed, and then you can use those spaces for a repeat trap in that area. Those viable conjunctiva will be helpful for a future trap.
Yes, that's a wonderful information for all of us. I think we have a lot to discuss as we move further on. Dr. Sathyan, please continue to stay with